I'm going to hit record. And now I want to introduce these two fine folks that have been sharing the screen with me. The first is Mary Catherine Colbert, and she's with an organization called DispatchHealth. Our paths crossed not too long ago, and she was telling me about the innovative things that this organization is doing and how they're expanding all over the country. And I was like, boy, we want to spotlight you. But mainly the reason I want to spotlight you is back in the olden days, before we did these online meetings, one of the best live events I did was at Virginia Hospital Center. And it was an emergency room physician who basically all he did was describe the difference between urgent care and emergency room care. And it blew all of our minds in the audience, and it opened our eyes up to why 9 out of 10 times when you walk into a hospital, into an emergency room, you're going to wait. Okay. So that's a little, I hope we can dive into that a little bit deeper. But Mary Catherine, tell us a little bit about yourself, and then introduce our panel member, Dr. Stadler.
Sure. Thanks so much, Steve, for having us. My name is Mary Catherine. I am with DispatchHealth. DispatchHealth is mobile acute care, and Dr. Stadler will talk about that towards the end. But we're all about not having to use the hospital when we don't need to. DispatchHealth has been around for 6 years across the country, started in Denver, been in Richmond for 4 years, and Dr. Stadler and I opened the Richmond market together, actually. And Dr. Stadler and I both worked at Bon Secours Health System, which is now Bon Secours Mercy. And Dr. Stadler is an ER doc, so he'll have all sorts of information to tell you. I have put my name and my information in the chat if anybody wants to talk to me afterwards about what DispatchHealth does. And how we can specifically partner with folks in Northern Virginia. But we just opened this location 3 weeks ago, and it has really taken off really quickly because the need is out there to receive care in the home. Dr. Stadler, as I said, is an ER physician, and he is DispatchHealth's medical director over strategy and innovation. So I'm really pleased that we're going to get to hear from him. Not only is he a wonderful doc, but he's a great friend of mine too. So Dr. Stadler, I'm going to turn it over to you.
I love it. All right. And before we jump in, I know Dr. Stadler, you've got some PowerPoints. That's fantastic. But I just want to remind our audience to, at any point in time in the discussion, if you've got a question or a comment for Dr. Stadler, use that Q&A box at the bottom of your screen and type it in, and we'll make sure that we address it. But really excited to have you, Dr. Stadler. If you want to try to share your screen here and we can kick this off.
Yeah, sure. Let me get started. I appreciate the opportunity today. I'm going to start sharing my screen. Like I said, my name is Carlton Stadler. I am an emergency medicine physician. It's going to be a little bit of different talk than you probably used to an ER doctor giving you. I was relieved to hear what Steve mentioned earlier about his experience at Virginia Hospital Center. But what I'm going to talk to you today is really a huge issue in this country, and it's even growing larger. And it's about aging in place. I'm going to talk to you about a $4 trillion healthcare problem that this country has, and what we're doing to solve that. What new and innovative ways are we approaching this? And what does the actor Owen Wilson have to do with it? All right, so a little bit of a spin there. Let's go on to our first slide. That was me. So what is the problem, right? We're waiting. Let's talk about emergency medicine for a second. You know, what's the worst part about going to an emergency room? It's the wait. We are so unsatisfied with healthcare in this country and the opportunities that are really outdated, that we're really searching for other ways to be able to get the care that we deserve and need. I mentioned before, there's a $4 trillion healthcare system that is truly unsustainable. And so it's reliant upon us as the healthcare team now to develop those strategies to improve consumer satisfaction, to improve our own satisfaction for the work that we're doing. You know, there's something interesting in medicine called a net promoter score. And I'll go back and talk about that for a second. There's something in this country called a net promoter score. A net promoter score is how satisfied are we with the service that we're providing, no matter what it is, whether it's Amazon or eBay or Apple. In this, and it ranges from 0 to 100. In this country, healthcare lives at less than 30% satisfaction by all of its consumers. And I think we all know why, because we're waiting. Companies like Amazon are in the 60s. Companies like Apple are sitting in the 70s. How do we raise the collective good, raising all boats by addressing this $4 trillion healthcare problem? No one really knows the right answer for how long we're supposed to wait. I think as a consumer, we want the answers now. One of the biggest challenges that we have in reducing that wait is certainly innovation and legislation. And I'm going to show you how we're addressing those issues. Let's talk about emergency medicine specifically. One of the biggest challenges to reducing wait times, as you've probably heard in the past, is the crowding that happens in emergency rooms. There are no beds available. And we're waiting for patients to be either released or moved upstairs. Overcrowding is certainly one issue. Psychiatric resources are an issue. Substance abuse issues certainly crowd emergency rooms too. These are not necessarily new problems, so why haven't we come up with a solution yet? Let's talk about what that should look like. Why doesn't anyone like going to the emergency room? Let's talk about emergency medicine specifically for just a minute. There's 150 million emergency visits alone just last year. That means that about 39 out of every 100 Americans needs to use the emergency room. Why? Well, oftentimes emergency medicine becomes the safety net. It's not just for emergent cases. That's not just what shows up there. Many of us use emergency medicine for those life-threatening illnesses, which really is what it's designed for. But these days, it's often being consumed with primary care needs. Like I mentioned, substance abuse problems. It's become that safety net. What happens if a primary care physician isn't able to get someone in? They'll oftentimes send them to the emergency room. And I don't necessarily, to be honest with you, think that's bad advice. I think that there are no other alternatives. And so we've got to help create those alternatives. What happens for patients after hours and weekends or when the books are full or over holidays? They end up going to an emergency room. I will tell you this, and in all transparency, 70% of what shows up in my emergency room tonight when I go on shift at 9 o'clock will be non-emergent. It will be things that could wait till the next day. It'll be things that are that didn't necessarily need a time-sensitive intervention, did not need emergent care. But truly, there were no other options. So what do we want as consumers, right? For those of you that are on the phone, I've got a meme up here of an LA freeway, and we want Chick-fil-A's drive-through line is really what it looks like. And just like Chick-fil-A, we want our care in under 5 minutes, right? And that's really the consumer society that we're in. There's got to be an easier way to be able to obtain these things. The current system, as we said, this $4 trillion issue is not sustainable. So what are we going to do? What's happened so far? We do have some new, but possibly advances. I think they're being sold probably as advances, but certainly it's a step in the right direction. Let's start with the first one. Let's talk about standalone emergency rooms. What is that? What does that mean? What is the difference between an ER, a standalone, and an urgent care? Well, that standalone emergency room has all of the capabilities that an ER attached to a hospital does, but it's out in the community. A lot of hospital systems use these as kind of feeder systems for their hospital. Certainly there are issues with that. Those also can become overcrowded. We've all seen these other retail medicine clinics, these minute clinics that have popped up. The retail clinics increase, what we're finding is that it's increasing medical use and spending at a lower level of care than what really emergency medicine is providing. So I think for some cases, there is a niche for that. And then recently, what have we seen over the past, say 20 months? we've seen telemedicine pop up, right? Telemedicine has been for lack of a better word, a lifesaver for those that needed to get medical care, were fearful of going to an emergency room, but wanted to stay in touch with providers. And so I think that we've seen that technology really pivot on a dime to be able to ramp up and become scalable to a point where it's easy to use for everybody. And I'll tell you something, I don't think we're there yet. I will tell you this, though. I think that the potential for telemedicine, we haven't even come close to tapping it. We are in the business at Dispatch Health of moving healthcare at home, helping people age in place. Why do we have to go into an emergency room if you've got companies that can roll up 70% of what an ER does, but does it in the home? What does that mean? That means the quality is the same or better. That means that there is greater patient satisfaction. There's greater patient compliance. But there are barriers to being able to do this, right? There are legislative barriers. And so what we've seen is these four companies, Dispatch Health, Intermountain Healthcare, Ascension, as well as Amazon, are beginning to lobby Congress to help make long-term changes to home healthcare reimbursement policies. The top priorities of the coalitions of these companies are advocating for providers to be reimbursed for those home healthcare visits at the same rate that a primary care office would be, and helping promote Medicare coverage for high acuity home care patients. Care Amazon participation in this new Moving Health Home initiative has also been very large. We think that upon rollout of this, upon rollout of the legislation, we're going to have a consumer-facing version of this that is going to allow employees of companies as well as commercial employees or commercial patients the ability to have that care at home, treating patients where they are, aging in place. Any questions about anything that I've mentioned so far? I know we may have some things come up in the chat that I'm happy to answer too, but I want to make this interactive. I want you all to feel like you can just jump in and ask me anything you'd like.
No, this is great. This is great. Fascinating stuff, Dr. Stadler. And yeah, I was blown away, like I said earlier, that I think the general public doesn't understand the difference between urgent and emergency care, which is what really clogs the pipeline. But man, those Chick-fil-A lines are incredible, aren't they? It's like
they're great.
You talk about an efficient organization that's figured out how to move their customers through their pipeline.
Yeah, you know, it's amazing what medicine is pulling in from different places. You know, lots of safety initiatives over the past 15 years have been pulled in from the aviation industry. Efficiency has been looked at through companies, again, like Chick-fil-A. I think that we're all learning, trying to figure out where our place is in order to be able to get to the goals. And instead of reinventing the wheel, we're really pulling in some of these best practices or best initiatives from other environments.
No, this is great. Well, just a reminder to folks, if you've got questions, you can type them in, or when we kind of open it up, you can raise your virtual hand. So I'm going to let you get back to the slide deck here.
Sure. I'd like to show you a few things just to give you a teaser into what the medical cost savings looks like, because these things happen with savings. And I think that that's really part of the coalition's goal, is to help our legislature realize that. With regard to Dispatch Health, I will tell you that Dispatch Health doing an acute care visit at home saves anywhere from $1,100 to $1,500 per visit. There's an initiative also called hospitalization at home, which I'll give you a teaser about in just a moment, where patients are hospitalized within their home. That saves an average of $5,500 per visit. I will tell you that the demand exists. All of us, I think, at some point in time, maybe even during this presentation, have said, wow, could I have stayed at home for this? It's a paradigm shift, right? It's that shift of, wow, they're actually coming to me. I will tell you that that demand exists because Dispatch over the past year over year, just year over year growth rate has increased 1 to 200%. There's a in all transparency, there's a common joke at DispatchHealth that if your slide deck is more than a week old, it's probably outdated, given the rapid expansion and growth of this initiative. What's interesting too, just to give you more of a teaser about this hospital at home, there's been a 20% mortality reduction for patients as compared to hospitalized patients. There's also concern that, is the hospital the right place? Is brick and mortar the right place for patients? I'm going to give you a small prediction here. I think that the hospitals of the future are going to be for three things. They're going to be for truly life and death, time-sensitive emergencies. They're going to be for surgeries, and they're going to be for intensive care units. I think medical surgical floors, step-down units are all going to be moving into the home. Let's talk about a couple of product lines just to give you all a teaser of what exactly is happening with Dispatch. DispatchHealth currently does the highest acuity and most complete system of care on the market in the home. Starting on that far left, the clinic without walls, right? This is an augmented televisit, right? It's that ability that I mentioned to in the beginning to be able to reach consumers in their home, which has been most important over the past 20 months. The most important one that I want to talk about today is this acute care visit. It's the emergency room substitution. If I've got a car with an emergency medicine trained team that shows up at a home and can do 70% of what an ER does in the home with greater patient satisfaction, greater compliance, what would be the downside to that? There's a product line also called Bridge Care. As you know, when patients are discharged from the hospital, the ability for them to have follow-up care or understand those 8 patient belonging bags that are full of medicines and machines and instructions, be able to understand all of those things, to continue to get the care at home that they need has been difficult. I'll tell you, last week I had to be on an antibiotic, and it was difficult for me to remember, be able to take that every single day. You can only imagine that patients who don't have all of their faculties or memory care diagnoses who need that level of assistance when they're discharged from the hospital. Extended care, so having nursing facility substitutions, being able to support those complex medical and post-surgical conditions from the hospital. And then advanced care, that hospital substitution or hospital at home model. I think what we'll find and what we're seeing with Dispatch is that acute care model is seeing patients in the home for an acute problem. Let's use the word COPD, emphysema. You have a flare-up of that. They determine the patient needs to be admitted to the hospital. They call the advanced team. The advanced team comes in and hospitalizes that patient in their home. Just as a teaser. In-home mobile imaging. I think the in-home mobile imaging market has been very rudimentary. I think that there have been several limitations. They can't go up at so many steps. They can only get an X-ray. I will tell you now that partnering with mobile imaging companies to implement in each of our markets has proven to be one of the largest, fastest growing mobile imaging companies in the country, with the ability to do extremity X-rays and chest X-rays and ultrasounds within the home. What's available in Northern Virginia? Let's talk about this acute care model. Each of the markets that we come into and we partner with people in the community for these markets, we introduce our acute care model. I mentioned before, it's 70% of what an ER does, but it does it in the home. We certainly screen those patients. We make sure that they don't have those time-sensitive emergencies. And then we send in our team. They show up with a wrapped Rover vehicle with emergency medicine trained providers. And I'll talk about more of those in just a moment. I'm also going to talk about the diagnostic capabilities as well as treatments, because people, in order for me to create that paradigm shift for you all, I want you to kind of picture these disease processes, what you could refer, what would you call for? So let's talk about the team that does come into the home. It's an emergency medicine trained nurse practitioner or physician's assistant. They do the head to toe assessment, medication reconciliations. They determine the treatment plan and they implement that treatment plan at the bedside. They're accompanied by a DispatchHealth medical technician that helps with those treatments, documentation, and just assisting the nurse practitioner or PA at the bedside. And then what's unique to this model is that there is an emergency medicine boarded and trained physician available to this team during the entire shift. And that's 8 a.m. to 10 p.m. in most markets. They're available to them for further diagnostic questions or just really be able to fine tune some of the treatments should it be necessary. So again, bringing that emergency medicine into the home. Requesting care for this has been easy. There's a telephone number that people call. They can log in on the internet and do it. You can even do it from the app on your phone. What is possible within the home? And I separate this, and I use this too because this is the leading full at-home care company in the country currently. So from a diagnostic perspective, it's a 12-lead hospital-grade EKG machine. We partner with mobile imaging. We have our own mobile imaging company. We have CLIA-certified labs, so moderate complexity labs. You know, sodium, potassium, bicarb, chloride, kidney function. We have be able to check urinalysis in the home. We also partner with labs to send out cultures. To be able to sit at the bedside and do rapid testing for COVID, influenza, mono, strep, RSV. From a procedural standpoint, you know, you think about 70% of what an emergency room does. We're doing wound care, lacerations, abscesses, boils, casting, splinting, durable medical equipment in the home. And then from a pharmaceutical perspective, these other three pillars are accompanied by the ability to do IV, IM, and PO antibiotics, antiemetics for nausea and vomiting, IV Lasix to get that fluid off of patients, nebulizer treatment, steroids, and even IV fluids for those with dehydration. People ask me all of the time, they say, Dr. what do I call you for? I see what you can do. I see your diagnostic pillars, but what do you guys get called for most often? And so I put a slide together just to kind of show you what is most often called for. And starting in the top left, just calling for influenza, weakness, falls, anxiety. We're able to evaluate eyes and look at eye injuries and stain an eye and be able to extract foreign bodies and styes. From a cardiology standpoint, palpitations, mild to moderate congestive heart failure, shortness of breath, retaining fluid. From a respiratory component, you know, I'm an emergency room physician. There's not a lot I can do in an ER for these patients that cannot be done at the bedside. And that would be, you know, very rarely, whether it's my practice or even a primary care office, are you able to have a provider, an emergency medicine provider, sit next to you for 45 minutes to an hour and a half straight, provide serial exams, provide those albuterol and Atrovent breathing treatments and steroids, and make those subtle differentiations between COPD, congestive heart failure, asthma, COVID, RSV, croup, pneumonia. With the ability of the diagnostics that we have, we've seen the greatest improvement, and that's really what we get called for most often. Nausea, vomiting, diarrhea, dehydration, constipation, kidney stones, urinary tract infections. I mentioned before abscesses, boils, lacerations. Neurologically, we get called for dizziness, determine what's the difference between, you know, migraine headaches and tension headaches and vascular headaches. Strains, sprains, contusions, and fractures, all well within the scope of what we do. And then nosebleeds, you know, removing foreign bodies, facial injuries, and lacerations. This is a fairly, again, it's kind of a sneak peek. I told you I'm really transparent. It's a look under the hood and exactly what we get called for most often. I want to take a break for a second to see if anybody has any questions about the clinical capabilities of what's currently being done in this new advanced healthcare at home model.
Yeah, we do have a few questions, and
Great.
I'm just going to run through them so that those folks know that we're recognizing them. But feel free to sort of say, "Hey, look, let me dive into that a little bit later." The first one is, are there any hard stops when it comes to patient issues? For example, if someone calls with shortness of breath or chest pain, Do you have to tell them to call 911, or can patients dealing with these issues still utilize your services?
That's a great question, and I am going to address that here. Probably, let me get through these other 3 questions, and then I'm going to address that because I think that's a very important question that we need to address in this issue.
Okay, and then let's see. Burke asks, can you compare how this works for people who live alone versus those who live with someone who can help after the medical team arrives? So I guess when your team arrives at somebody who's all by themselves versus somebody who might have a home care provider there or a loved one living at home.
Yeah.
And let's see. Kim asks, how do you treat a kidney stone at home if it does not pass on its own? A family member had to have non-invasive surgery. Bob asks, please explain the relationship to Medicare with the other health payment systems as it relates to this type of services. And then Carol says, what additional training is needed or required for nurses, PAs, et cetera, wanting to transition to this new career path? We have a lot of providers on this call. Extra licenses provided? Do personnel need to be supervised? How is performance appraised? So again, I love these discussions because our audience is so interactive. That gives you a few things that are on people's minds, and feel free to kind of move this in any direction that works for you.
Yeah, those are some really important questions. And I think in an effort to be mindful of everyone's time today, I pulled out a couple of slides that would probably address that. But let me do that. And I want to start with the most important question that I heard. Okay. How do you know that this is something that we can treat in the home versus a time-sensitive emergency? I will tell you that I'm not treating heart attacks. I'm not treating strokes. I'm not putting in central lines or chest tubes in the home. We have developed a risk stratification protocol, and it's part of that onboarding process where we risk stratify patients. And actually, we have a patent out on the stratification protocol currently, where we have 60 plus protocols where we go through and we will ask you the questions that will rule out that time-sensitive urgency. We place patients in one of 3 categories. A red patient, which is a patient that needs to be escalated to an emergency room. And we certainly provide those escalations and those warm handoffs to emergency care when they need it. And that would be those time-sensitive, a heart attack or a stroke symptoms. Oftentimes patients fall into our green category. In fact, over 95% fall into the green category, which is patients that we continue to onboard because it's well within our scope of practice. And then sometimes in the middle, right? Further questions are needed to be asked. So from a patient safety perspective, that is a proprietary risk stratification protocol to get people there. From the next question that I heard was, what do we do if we have a person at the home that is able to help or assist? And oftentimes I'll correlate this also well with the onboarding process and power of attorney. We often have care providers or family members or powers of attorney or just advocates that are at our bedside, a neighbor that's able to help. We certainly involve them in the process, and part of what we do is an educational piece. Certainly, we're going to continue to educate you on your disease process. We're going to provide a little bit of educational information, give you a list of reasons why you would want to call us back, okay? But also give you those warning signs of why you would want to go to an emergency room should symptoms become severe or time-sensitively emergent. I think that, involving those people at the bedside, whether it's power of attorney or a neighbor or friend or family, as advocates certainly helps that support system. One of the nice pieces that we do, and primary care offices love us for this, is we act as an extension of that primary care doctor's office. And we're into the home and we do the social determinants of health. Many of you realize that social determinants of health cause patients to fall between those white spaces in care, whether it's that rug they keep tripping over. And we'll use an example later of a patient that whose roommate smoked and had 6 cats, and she kept showing up to an emergency room for COPD. So those things that we don't necessarily pick up on in our clinics or in the emergency room or urgent care. What are the financial needs and resources of those patients? So taking all of that as well, being able to report that back to the primary team to keep patients in that care stream.
Yeah, thanks for answering Burke. Burke, hopefully that answered your question about the in-home, but as you talk, I've talked to so many healthcare providers, whether it be physicians or case managers who are discharging or giving instructions to their patients in their office or their facility-based environment, sending them home. And what you realize is the blind spot that we've got in our system, in that, most of these homes are not anywhere near set up to be safe, accessible, and clean for somebody to recover or go through their process. And the ability for you all to be there and to see the red flags at the point of contact, I think is really exceptional.
Yeah, it's interesting. I hear cases all the time where they'll say, we went in, we followed up with this patient, and they were weak and tired, and we looked in the fridge and they had no food.
Yeah,
they're bed bound. All of those things weigh in, because that's a patient absorbs all of those things when they come home, and those, as Steve mentioned, are impediments to the care and getting better.
Now, imagine in some of your markets, because you've been around and you're pioneering in this area, been around for 6 years, is that, I guess, in certain situations, you come into an environment and it may be that you're sort of rallying, adult protective services or other organizations if there is, an unsafe environment there for the person that is living at home. Is that occurred?
Yeah, you're exactly right. And that's not necessarily uncommon. I think what we also, adult protective is one area. I think that in that in-home safety evaluation that we do is very important. I think what we also find ourselves doing is coordinating the care with their primary team, occupational therapy, physical therapy, wound care. What are the other social programs within the system that referred us out there that we need to keep those patients plugged into?
Okay, I'm gonna shut up here and let you get back to the program. But again, thanks for these great questions that folks are asking.
Sure. I'll give you, from a clinical perspective, we're talking about clinical medicine here. I want to address the clinical question of the kidney stone. Kidney stones are, most of the time calcium deposits that come out of the kidney and go down the ureter and into the bladder, causing obviously severe pain. Be able to treat those patients with anti-inflammatory or IV pain medicine, IV fluid, as well as Flomax, in order to be able to create back pressure to have those pass. Now that's just one piece of it, right? Education is a huge piece. And someone had mentioned, what about those recalcitrant stones that aren't getting better? Being able to provide patients, prescriptions to be able to be filled should they need that. But again, those warning signs in order to be able to follow up should something else be necessary. We're also able to assess, is it an infected stone? That's another issue. Are we losing blood through the urine? Are we losing protein? What's the kidney function look like? So all of those things that we're able to do in an emergency room with regard to treatment, so much of that we're able to do in the home. At the end, I'm going to let Mary Catherine talk about the Medicare question, and then we'll also talk about the additional training that our providers go through. So, Mary Catherine and I kind of went back and forth on do we show this map? Do we not show this map? Like I said, if the slides are more than a week old, they're out of date. And I will tell you that we started this year, I think, in 23 markets, and now we're in up to 43 markets. And this really could be updated even more than it was. Before we went to print on this, I was not able to get an updated map, but it is rapidly expanding with not only hospital systems, primary care groups, payers. All of them are trying to bring us into those markets. Let's see. let's talk about what is the cost savings, and Mary Catherine can feel free to jump in here too. What is the average cost of this? This bills out as an urgent care visit, even though it is an emergency room alternative. And so the average cost to seniors for Medicare patients with secondary insurance is $5.44. And these are averages over the past year. We accept Medicare, Medicare Advantage, as well as commercial insurance, as well as private pay. The teams bill our teams bill directly for the care. There's no money exchanged at the bedside or anything like that. And like we said, it's 80 to 90% less than going to an emergency room. Medicare without secondary insurance was $27.31, and the Medicare Advantage average was $17.33. Mary Catherine, anything that you feel like we need to add to that, or that they might be having questions about?
In this market, I know Kaiser is here as an MA plan, and we do not accept that MA plan. I hate to say that. So that is one thing I wanted to tell about Northern Virginia. But just as Carlton said, I mean, I'll talk about my own father, who's 85, and Medicare and DispatchHealth has seen him probably 7 times over the past 4 years we've been open in Richmond, and I've never seen a bill. He's got Medicare and a secondary, and I've never gotten a bill from Dispatch for his visits. So as commercial goes, it's whatever your urgent care copay is on your insurance card. So we've seen both of my children too at DispatchHealth, and they are now 18 and 21. And their visits were $75 each, the exact same price as if you got up, got dressed, drove yourself to an urgent care, patient first, better med, kid med, whatever that copay is. But now you can just call us and you don't even have to get out of your pajamas. You can just hang out at your own home. But yeah, so I think this hopefully will just answers the Medicare question that was posed in the chat. But if you need more information, please ask, a more detailed question. But yep. We're inexpensive compared to what you think. We look like concierge medicine, and we feel like that, but we're not the same price. We're covered by insurance.
And we mentioned that we do bill out at urgent care rates, but we're providing care that far exceeds what an urgent care can do. It really is an emergency room alternative.
Right. And I'm sorry, one more thing. If you are uninsured, the flat rate for our visit is $275. And we do ask for payment if you are uninsured, but otherwise, if you have insurance, we want to bill all your insurances first before we collect any sort of copay. But if you are uninsured, it's $275, and that's all in. For whatever Carlton talked about we can do in the home, it's all under that $275. It's not $275 to show up and then we add. It's $275 for whatever we do while we are with you in the home. If we order x-rays, X-ray has their own bill. If we send your culture out to the lab has their own price as well. But for whatever we do, it's covered under that $275.
That's great. Thank you, Mary Catherine. I want to put a couple of case studies up here, and again, to kind of finish out this paradigm shift for everybody to make this really granular and where the rubber hits the road for everybody to understand. And these are real case presentations, and actually within Dispatch, the most amount of time is probably put into these case presentations because they truly do keep us all very patient-centered, and they are the most proof of concept of what we're doing. This is a real case of an 80-year-old female. She lives in an assisted living community who's been experiencing some confusion and agitation all day as reported by the staff. They think that's the same type of behavior last time when she had a urinary tract infection. The daughter, who's a power of attorney, consented for us to actually come and see the patient. When the team showed up at the home in the wrapped vehicle, full head to toe assessment exam, they found her slightly agitated. She had some pain to palpation over her lower abdomen, but certainly no signs of dehydration. At the bedside, the team performed a straight cath to get a urine specimen. They did a urinalysis. Because it was positive, they sent that out for cultures. Patient was encouraged to increase PO intake. No IV fluids were necessary at the time because she was hydrated and tolerating PO. She was started on an antibiotic and was provided a prescription for Bactrim. And then the AL staff was given the clinical notes. So we circle those notes back to the primary care team 94% of the time. It's not 100% because not everyone has a primary care provider, but again, we are lockstep with the primary care team on what we're doing, getting those notes back to them. So we were able to, at the bedside, see and evaluate this patient. She got a cath as well as a urine, a culture, got a prescription, got all of the notes sent back to the primary care team. She didn't show up in an ER and wait 6 hours or have that level of trauma of having to wait and for her treatment. She got all of that in the comfort of her home. Next case I want to show you. Back one. Little bit, and I put this case in here because I really want to highlight the high acuity that we are really capable of. So we've got a patient with COPD, 5 days of cough and shortness of breath. Symptoms were made worse with walking. The cough was productive. Past medical history of reflux, hypertension, and diabetes. And oh, by the way, the patient was morbidly obese. On exam, the team that showed up found the patient with oxygen saturations at 93%. Patient was comfortable, but had some significant shortness of breath anytime they got up and their oxygen saturations dropped. On exam, they found some wheezes, some slight crackles, but certainly no edema. After the full review of systems and physical exam, they determined that the patient needed nebulizer treatments as well as Solumedrol because their presentation was consistent with acute on chronic COPD versus pneumonia. They started the patient on antibiotics for presumed pneumonia. They obtained that chest x-ray and confirmed that this patient had a right lower lobe infiltrate. They provided aftercare follow-up for the patient, ensured that they had someone that could see them in the next 24 to 48 hours. Sometimes if that's not possible, we will schedule a second visit for them. And then we followed up with them a week later. A week later, it turns out patient wasn't able to get into their PCP due to lack of appointments, and we came into the home. Still had a little bit of a cough, no low-grade fever anymore. We adjusted the antibiotics at that point in time, ordered some home nebulizers and medications for them, contacted that primary care office from the bedside, and scheduled that follow-up visit in 2 days and ensured the patient could get there. We then followed up a week later. Patient was improved. Repeat chest x-ray showed that it was clearing. So again, patient with multiple medical problems, but this is a classic bread and butter of what we see. We were able to manage the patient at home with medication, the chest x-ray, as well as labs. We gave them, Solumedrol, antibiotics, and nebulizers. We helped with that PCP appointment. There was no transport to an emergency room. It was 80% of the cost. We coordinated with the primary care doctor. And I'll tell you something, that doesn't happen. How many of you know that your patient shows up to an ER and ER doctor changes medications and, who doesn't even know the patient, right? And so that lack of continuity, taking patients out of that healthcare stream has really been, as you all have seen, deleterious. I certainly warn all of my ER doctors, by the way, please don't touch those medications unless you talk to a primary care team. But certainly you can imagine, the patient satisfaction and really, again, proof of concept at them getting better at the bedside.
Hey, Carlton, there was a question about on the case study prior about what would we have done if that patient, the first case study, if she had needed fluids, what would we have done? Can you, I mean, I know what I would say, but I want you, because you're the doctor, what would we have done?
Absolutely. So assessing the level of dehydration, and that can be done certainly with urine, it can be done with labs, providing IV hydration for that patient. And also orthostatic vitals is sometimes important with regard to that, as I mentioned, the labs and the urine. And then getting that patient to a point where they can tolerate PO. So, to give a patient a liter of fluid at the bedside is well within the scope of what we do, and is done every single day when we're in the field. Great point.
Thank you.
Great. This is awesome. And, going back to Carol's question about joining the DispatchHealth team as you guys enter this market. And also, Mary Catherine, before we started, you mentioned that you've got an outreach position that you're recruiting for. Maybe you could kind of give an overview of how folks could potentially join your team.
Yeah, sure.
Yeah, you go first, Carlton.
I'll talk on the clinical side. I am looking for, and because we are rapidly expanding in this market, I'm looking for emergency medicine trained providers. I need someone who's at the bedside who can act as the eyes and ears of either a primary team or even one of our emergency room doctors on the phone, to know the difference between sick and not sick, and what is a time-sensitive emergency. Certainly, all of our providers go through our Dispatch University, which is something that we provide, but there is no licensing or certification other than what would be required by the state in order to be able to do those things. So all of our providers are emergency medicine trained or worked in emergency medicine in the past, PA or NP in this market.
Mary just typed in an answer to a question from Bob, and it says, are there calls deemed to be too minor for service? Example, a small cut that just requires cleaning or a bandage with no stitches.
Yeah. And I mentioned, we sometimes screen and say, can you get to your primary care doctor? Is that an option? And if it's not, that's great. It all really depends on how busy we are for the day, which we do get full, because right now in Northern Virginia, we only have 2 cars. So just like the doctor's office, we can get full as well. But we will absolutely come and see minor cuts. Right, Dr. Stadler?
Yeah, and it's one of those things where, I remind providers all of the time in the emergency room, it's not my emergency, it's theirs, right? And lack of medical knowledge or understanding and wanting that level of reassurance is sometimes their emergency. So sometimes we push patients to their primary care team, sometimes we push them to an emergency room. But 95% of cases we're actually seeing in the home. Good point.
Great. Mandy asks, do you have to obtain consent before going out to see a patient? What is your turnaround time between patient calling with a concern and a visit from one of your team?
Yeah, that's a great question. Thank you, Mandy, for bringing that up. We always need to get consent from the patient or the POA prior to setting an appointment up. We will never just show up at a home without talking to the POA or the MPOA. Average time right now, it's always our goal, I should say, to be at the patient's house within an hour to 2 hours of them calling for care. I will say COVID has set us on our edge about that with COVID testing and, the heightened awareness of not wanting to be with other people when you're sick. So it's, on average between an hour and 2 hours. And that's always discussed with the patient before we set that time. And if you call us and the wait time's too long, and you don't want to wait that long, you may certainly say thank you, but no. I will say, though, in today's environment, it's probably just as long to wait for us to come to your house as it would be to go and wait in an emergency room and or a patient first before you're actually seen by a provider. So, but it's really all up to the patient and their comfort level. Just like Carlton said, it's your emergency. It's what's comfortable for you, not, on our side. We'll just tell you what we can do. And then if you're up for it, we will set that appointment and give you that ETA.
Great. How would a patient who's dehydrated and has a UTI be handled? Many older adults would benefit from an IV fluid bag to keep them hydrated and to decrease the chances of getting UTIs, keep them out of the hospital. Is there a maintenance IV fluid program available?
Currently there's not a maintenance IV fluid program. I think what we would find ourselves in a position, if we did something like that, and that's a great suggestion, we'd find ourselves being a continuity partner as opposed to an acute care partner. We firmly believe that patients belong with their primary care teams. We have, things in place to ensure we don't overutilize the service. But no, that would probably change our perspective on things too. More chronically involved.
Yeah, but we do see folks more than, I do want to say this too, but as Carlton says, we have protocols around seeing people if it's a chronic issue, and Dr. Stadler and other docs in our organization look at cases like that. But we see folks for UTI, especially in senior living. And I'll say my dad is one of those in memory care, and we will take care of those. But as Carlton said, we do want to hook people up with a primary care. We do want to make sure they have folks to take care of them on long term, because we really are there for that acute episode, for that urgent situation.
Great. And Bob Hoffman gets the gold star today because he has definitely asked the best questions.
I agree.
Is there a formal procedure to sign up for dispatch services as a member? Is there any fee to join? And also, as I mentioned earlier, there's a lot of healthcare and senior living providers in the audience. How do they establish a formal relationship? And is there sort of a joining or a cost involved?
Yep. So no cost to join. There's no sign up fee and there's no pre-registration. You just call us when you need us. As far as a senior living community, the best thing is to chat with me. Again, there's no sort of sign up, but I would want to make sure that my providers going into your community, which is your home, have all the knowledge they need on how you'd like to be communicated with, how the staff would like to be communicated with, what we need to do on scene. You know, do we go to the wellness office and pick up the chart? Or are we going to get the face sheet? You know, there are things that in a senior living community that are more specific. So I recommend reaching out to me, but still there's no cost to anybody but the patient, and we bill insurance, and that's how we work. And we are a partner with home health, personal care, independent living, senior living, the general community, all on team. Don't go back to the hospital. And so however I can work with any of these entities on forming those relationships, just so we know how we want to work together, is great. But there's no sign up, no pre-registration, no cost on that side.
There's a question on the different markets that you serve, and I am going to type in the link to all the different markets nationwide into chat for you all. It's there. As you had mentioned, this was launched in Colorado, I believe.
Yes, in Denver, Colorado, correct. And we do have 43 markets across the country as of November 18th. Orange County, California was launched, and then we'll launch, I don't know, Carlton, at least I would say 10 to 15 next year. I mean, I've seen the anticipated list, so.
Yeah, it's going to be 10 to 12. It's going to be 10 to 12 with just a nice, steady, intentional, prescriptive rollout for each market.
Let's see, and somebody asks, who do we call? And our audience has expanded. We got a lot of people in Maryland, so I knew this was happening.
Right. We talked about that, Steve, right?
And they said, who do we call if we want Dispatch Health to consider offering your services in our city, town, or state?
So you can certainly let me know. I do know that Baltimore is on the radar for next year. I have heard that. I don't, and you know, it all depends, as Carlton knows, about, as you mentioned, the payers, the health systems, provider groups that partner with us. We like to have an anchor in the cities we open up in. So I know Baltimore is on the list. I just don't know exactly when, but anyone can reach out to me. We have lots of national partnerships with different senior living, home health, personal care agencies all across the country. So I just want to make sure that everybody is informed, but you know, please get in touch. Texting me or calling me is the best way to get in touch.
Great. Okay.
And I think we want to talk about my position too, or this position, the business development.
Yeah, your outreach position.
Yeah.
And so let's well, first off, you know, Bob Hoffman, again, our Gold Star winner today, says, congratulations on creating a new model with old school principles.
That's
and I couldn't
right.
agree more.
That's awesome. Thank you.
This is really exciting. And as I look at the clock, we are winding down to the top of the hour. So this is a great way to close, Mary Catherine. Tell folks about this outreach position. And then if you send me the link, I'll make sure to share it with folks.
Yep, and I will look for that. We do post our jobs on Indeed. It's a business development representative position for Northern Virginia. And I am opening the market, but I would love to find somebody with healthcare knowledge is great, knowledge of the older adult community, because that is our largest bandwidth, is seeing people 70 to 79 years old. But people that are really out and want to help this really innovative, I still feel it's a startup in each town we open up in, right? To really build this business and close that gap between, you know, needing care in the emergency room and people going back to the hospital. So we do have them on Indeed. You can look up Dispatch Health there, and I will try and find a link. But yeah, apply if you're into it. If what you heard sounded good, we'd love to have you on the team.
Great, excellent. And Dr. Stadler, you have any sort of closing statements? I want to remind everybody we recorded this. We'll post this up and put it in podcast so you can share it with your colleagues and your loved ones.
No, thank you for the opportunity. Again, if you haven't heard of Dispatch, you will very shortly. Thank you all for your time today.
Excellent. And all right. Well, I look forward to seeing some of you on our discussion tomorrow. I want to thank the two of you all for really joining us and introducing what I know is going to be an important platform. So we'll see y'all soon.
Thank you all.